Thank you for your interest in the DOPPS Practice Monitor. I am going to present here some most recent data related to mineral and bone disorder that are contained in the most recent update of the DPM that was released in September 2015. In the absence of ultimate evidence from randomized controlled clinical trials testing the impact of PTH levels on clinical outcomes, there is strong evidence from observational studies that extreme values of PTH are associated with adverse outcomes in dialysis patients. These are findings from the DOPPS study that were recently published. And as you can see, both very low PTH at the left-hand side as well as higher levels were associated with all-cause mortality as well as cardiovascular mortality and hospital admission. At the low end, probably we see patients who are either overtreated or who are not able to develop high levels of PTH. On the other hand, at a level above 300, you see how there is an increased risk of mortality. And for these patients, there is an opportunity for improvement in terms of treatment. We recently looked at trends in PTH values given these associations that were demonstrated, and we saw in the DPM sample a constant rise in PTH levels over the past year. This has been particularly significant at the high end. So as you can see, for the 90th percentile displayed in orange, there was an 18% increase from December 2013 to April 2015, with 10% or more of patients in the U.S. right now with PTH values above 930. This is clearly a level that has been associated in all studies with adverse outcomes, and I think this calls out an opportunity for improvement in the care of dialysis patients. What's disconcerting as well is that the rise in PTH has particularly been burdensome for Black patients. So because Black patients tend to have higher PTH levels, while the rise was similar among Blacks and non-Blacks, right now 1/3 of Black patients have PTH level above 600, which again indicates a strong risk factor for adverse outcomes in this racial group. So what can we do in terms of treatment of high PTH level? Of course, one mainstream way of treating hyperparathyroidism has been administration of vitamin D, and this represents the percentage of patients receiving any active vitamin D over the prior 3 months. This includes oral or IV administration. And this percentage has been constant over since the beginning of the DPM, about 80%. However, we are now observing a very interesting trend with a much higher proportion of patients now being prescribed oral vitamin D, either in combination with IV vitamin D, 13% in April 2015, or in isolation, oral vitamin D only, which is represented in yellow, and it's now 18% of the DPM sample. This is a new practice for the U.S. DOPPS data have shown that oral administration of vitamin D is relatively common in European countries, but it's a very new trend that the DPM was able to show because of the very timely update of data that we are able to provide. The reason for this are not well understood. There is a thought that perhaps oral administration of vitamin D may result in less hypercalcemia, and so perhaps people who might be concerned about the hypercalcemia quality measure that is included in the QIP might be switching to oral vitamin D. Also, cost of oral drugs that are not included in the bundle might be another factor playing in this change. While we still need to do work in terms of understanding this practice, we feel that it's really important to call this out and to continue to monitor in upcoming months. In terms of other therapies related to mineral and bone disorder, certainly with regards to cinacalcet, we haven't seen any particular trend, and the percentage of patients prescribed cinacalcet remains stable at about 27%. With regards to phosphate binder, again, perhaps just a slight decline, with about 84% of patients being on any type of phosphate binder. The levels of phosphorus and calcium both have remained very, very stable over time. One topic that we are very interested in is looking at the combination of different markers of mineral and bone disorder. And so here we are looking at the number of MBD markers that are defined as out of range, and the range we used are specified in the footnote. There is pretty strong evidence that being outside of target for more than one marker is associated with an increased risk compared to the association of each single marker. So here we show the proportion of patients who are within target for all our three markers, which is 39% in blue. Those who are in target for one marker, it doesn't matter which one, it could be PTH, calcium, or phosphorus, for two markers and for three markers. So at least 24% of patients have two or more markers outside of range. Given that each of PTH, calcium, and phosphorus have been associated with adverse outcomes, there is, again, evidence that we can improve the care of mineral and bone disorder in dialysis patients. So which one are the markers or the combination of markers that most commonly contribute to this dysregulations? As you can see, the majority of patients who were out of target for two markers or more had PTH and phosphorus levels out of target, and that represent 61% of all. About 25% had a combination of phosphorus and calcium, and the remaining is PTH and calcium. Given the complexity of MBD, we all know that in clinical care, it's important to act on all three of these indicators. And again, we believe that it's important to continue to look at this combination as an opportunity for improvement for the care of dialysis patients. So to summarize the most recent trends in mineral and bone disorder that we have observed in the DPM, it appears that median serum PTH levels are rising again. From December 2013, the median was 313, to April 2015 to 370, and this is particularly troublesome among Black patients, where now more than a third of them has the PTH values above 600. We also have recently observed this change in the pattern of vitamin D prescription with an increased use of oral vitamin D, either in isolation, which could be as a replacement for vitamin D that was previously administered in IV, or in combination with IV vitamin D. And we have seen a declining trend in phosphate binder prescription, while both phosphorus and calcium levels have remained stable. Thank you again for your interest in the DOPPS. If you are interested in more information from the DPM, please see our website at dopps.org/DPM.